Yeah, that's fine. Yeah, thank you. Good morning, everyone. I thank the organizers for this opportunity. Now we'll discuss about the novel and the targeted agents in gastric cancer. We know that a lot of trials have been underway for adjuvant and the neoadjuvant setting in gastric cancer, but none have been approved. So we will be discussing the agents which have been approved in the advanced gastric cancer and the novel agents which are in pipeline. So this is the algorithm. When you see newly diagnosed esophagogastric cancer advanced, we have to check the histology of the tumor. We have to check the histology of the tumor and the biomarker testing, which is very important in choosing the therapy, like HER2, PD-L1, and MSI at least. And if it's a HER2 positive disease and the candidate is eligible for trastuzumab, then we can go for a trastuzumab with chemotherapy based on the TOGA trial, or with the same set of patients, we can add a pembrolizumab based on Keynote 811. We'll be discussing in the further slides. And if it is negative, then check whether it's a MSI or the PD-L1 positive. Then we can add immune checkpoint inhibitor along with the cytotoxic chemotherapy. So biomarker testing is the most important thing when you are choosing therapy in advanced gastroesophageal cancers, and who all should be tested? All newly diagnosed patients, and for these are the markers like HER2, MSI, PD-L1, which are most important, and of course NTRK fusions and the comprehensive genomic profiling if enough tissue is available. So how to choose the immune checkpoint inhibitors based on the PD-L1 levels, which is based on IHC testing. The PD-L1 may be positive in approximately 50% of the gastric cancers, but only if a combined positive score is more than 10, then only these agents are effective. That is the PD-L1 staining cells, including the tumor cells, lymphocytes, macrophages, with the denominator of the total number of tumor cells evaluated into 100. CPS score more than 10 is more important in these tumors. And how do we assess HER2 testing by IHC? It's gastric cancer HER2 testing is totally different from the breast cancer HER2 testing in the sense how the circumferential membrane staining and it should be complete and intense in the breast cancer, more than 10% of tumor cells. Whereas if you go for the gastric cancer, it depends on whether it's a surgical specimen or the biopsy specimen. If it's a surgical specimen, even a complete basolateral or lateral membrane staining in more than 10% cells, we need to consider as a positive disease. That means even the lateral membrane staining is more than sufficient. It doesn't need a complete circumferential staining. And when you take the biopsy specimen, even regardless of the number of tumor cells, only a lateral membrane staining is more than sufficient to consider it as a positive HER2 disease. So it's a simple algorithm to choose the therapy in advanced gastroesophageal adenocarcinomas. If it is a HER2 positive, add a trastuzumab based on TOGA trial, or you can incorporate immune checkpoint inhibitor pembrolizumab based on Keynote 811. And if it is negative, the biomarkers are negative and HER2 is negative, then chemotherapy will be the good choice. This is a well-known trial, TOGA trial, where trastuzumab has shown improved survivals, median overall survival compared to chemotherapy alone, with a hazard ratio of 0.65. In the same set of patients, if you add pembrolizumab, that TOGA regimen, along with the pembrolizumab, when it was compared with the placebo, which was given for up to 35 cycles, with a primary endpoint of overall survival and the PFS, you can see the interim analysis showing the efficacy of overall response rates of almost 75% when you add pembrolizumab to the trastuzumab based chemotherapy, and 50% for the other arm. So there is an improvement of 23% of response rates when you add pembrolizumab to the backbone. So this is a waterfall plot showing the same, a very good and deeper responses and more number of responses when we add immune checkpoint inhibitor to the TOGA regimen. So once the HER2 is tested, and if you are going for a trastuzumab or pembrolizumab, would be with a good survival rates. But if it is a negative, then you assess the MSI to choose the immune checkpoint inhibitors. So concentrate on the right side curves, where these are for the first line pembrolizumab when you have a high MSI. This overall population where the curves are crossing and we are not interested in, and with a hazard ratio of 0.9, where we shouldn't be using the immune checkpoint inhibitors, but only in the patients with MSI high, even the number of subjects are less, you can see the clear cut separation of the curves with very good hazard ratio of 0.29. So MSI high tumors, definitely pembrolizumab is one of the option versus the chemotherapy. So MSI high, we seen that the either nivolumab or pembrolizumab can be used along with chemotherapy. And if that is also negative, then check for the PDL1 levels. So based on the PDL1 levels, we can again use immune checkpoint inhibitors with the chemotherapy. In this study, Checkmate 649, even though it has 3 arms, but these curves are for nivolumab plus chemotherapy plus or minus nivolumab. When you add nivolumab with chemotherapy, especially when the PDL1 is more than 5, they have a median overall survival advantage of almost 3 months with a hazard ratio of 0.7. This is like unselected population, we have a hazard ratio of 0.8. In the subgroup analysis, the hazard ratio is much significant for the CPS more than 5. And you can see this, the MSI status. Who have MSI high, you have a hazard ratio of 0.38. That means MSI high and the PDL1 more than 5, nivolumab is being approved and with a significant survival benefit. All the other subgroups, they have almost like 0.6 to 0.7 hazard ratios. This other trial where incorporation of pembrolizumab to chemotherapy in a PDL1 positive patients. In this study, they could notice that CPS more than 10 had a very good benefit of survival of more than 4 months with a hazard ratio of 0.62. CPS more than 10, then you have a significant benefit. But if it is like CPS less than 10, you can see the hazard ratio of 0.86. So I would like to convey that only CPS more than 10, we should be incorporating pembrolizumab along with chemotherapy, even though PDL1 is positive. That's the first line agents. We have seen trastuzumab, the target therapies, and the immune checkpoint inhibitors where we have to use it. When you come for the second line, again, it depends on whether it's a molecularly informed or not. Molecularly informed, again, we'll check for the HER2 positivity or the other by NGS testing, NTRK or MSI or TMB, tumor mutation burden. Where there is no molecular targets, then the good drug would be Cyramza with paclitaxel. So when you have a trastuzumab, like a HER2 positive disease in the second line, who have earlier had more than 2 prior lines of regimens with or without trastuzumab, a TDX drug compared to the physician's choice, where they assess the overall response rates, you could see the difference between the physician's choice and the TDX, where a significant difference in the overall response rates of 50 versus 14%. And these are the survival curves for the same trial, TDX versus the physician's choice, with a hazard ratio of 0.6 for median overall survival, benefit of almost 3 to 4 months. This is Destiny Gastric 2 trial, where all the patients were exposed to the trastuzumab, whereas the Gastric 1 trial, it is just the chemotherapy plus or minus trastuzumab. But in Gastric 2 trial, all of them were exposed to trastuzumab. Here you can see the response rates of almost 40%. So what are the other novel HER2-directed strategies? We have margetuximab, zanitumab, and TKIs like tucatinib, neratinib. Margetuximab have been studied in phase 1b/2 study with a combination of pembrolizumab with overall response rates of around 30%, which is not very much impressive. But zanitumab combined with or without chemotherapy, who had a prior therapy disease also, prior therapy patients also, they had a very good response rates. When you combine the agent with the chemotherapy, you can see around 57% of response rates, which is very much significant, looks promising. So where there is a molecularly uninformed, so we depend on VEGF inhibitors, the ramucirumab along with the taxane. It is a second-line trial, the Rainbow trial, with a median overall survival benefit of around 2 months, hazard ratio of 0.8, and the overall response rates is around 27% versus 16%. This is an important slide where ramucirumab with taxane have given very good responses. That's almost like 60%. In the Rainbow trial, we have seen 27%. But in this one, they have noticed 60% of responses when we use ramucirumab with taxane, who have been exposed earlier with the immune checkpoint inhibitors. The concept behind this would be the anti-HF will enable the efficient priming of activation of the T cell responses. There will be an ongoing immune response that is recognizing and recruiting by normalizing the tumor vasculature. It will result in the infiltration of the more T cells into the tumor and restoring the immunomodulatory effects by the anti-VEGF drug. And one more is reprogramming of the tumor microenvironment. These are all the actions, the concept behind getting a higher response rates when we use ramucirumab with taxane who have been exposed to the immunotherapy, immune checkpoint inhibitors earlier. These two curves are the different. The blue one is for patients who have been exposed earlier with the ICI, and the red one is not. So you can see the clear-cut difference between these two set of patients. So as I said, the molecularly uninformed, we can go for ramucirumab, and especially it works very well if they have already been exposed to immune checkpoint inhibitors. And in the second line, the same slide which you have seen earlier, this is the first line, keynote 62 for pembrolizumab, and these in the second line, who have a PD-L1 positive of a CPS more than 10, they have responses with pembrolizumab versus chemotherapy, and it shouldn't be used if it is not checked. You can see the curves are crossing and not giving any benefit with a hazard ratio of 0.9. Even though the MSI, PD-L1 all are negative, if you check for TMB, if the tumor mutation burden is more than 10%, which is seen around 10% of the gastric cancers, and TMB is more than 10, you can see the survival curves difference when we use the immune checkpoint inhibitors, pembrolizumab, with a hazard ratio of 0.52. But people who have a tumor mutation burden less than 10, they are doing worse. The chemotherapy is much better than them. So either MSI high or PD-L1 CPS more than 10 or having a tumor mutational burden more than 10, then we can use immune checkpoint inhibitors in corporation. So how to test all these markers? We have know that the biomarker testing is the most important, and the NGS would be a right tool to identify most of the biomarkers. And but the PD-L1 and the claudin expression would be tested by IHC. So when you come for the other biomarkers like in the NGS testing, if you're able to find like FGFR positivity or EGFR amplification or MET amplification, you can target the drugs based on these biomarkers. This is the drug bemarituzumab, which is an anti-FGFR2 antibody in a de novo detected, de novo locally advanced metastatic gastric cancer. You can see the response. You can see the PFS probability and the overall survival probability by addition of this agent. 12-month rates is around 56 versus 65 with a hazard ratio of 0.6. These are all the novel agents which are in pipeline. And EGFR can be tested, which is a older target, and subgroup analysis have shown that EGFR amplification may benefit with EGFR inhibitors. There are a lot of trials undergoing with a lot of agents. And MET is still a viable target where MET amplified tumors will respond to the MET. So FGFR, EGFR, MET testing is also important in advanced gastric adenocarcinomas. So the last biomarker would be the claudin. Claudin, it's a molecule which is like the structural component of the intercellular tight junctions, which are normally seen in the gastric epithelium, but not in the other tissues. And it is expressed in other solid tumors also. Right, targeting this claudin by zolbetuximab, it's a drug which will, it's a antibody which will target this claudin expression on the tumor cells. You can see the patients who have a high claudin expression, they have a very good response rates, almost like 8 versus 16 months, almost doubling the overall survivals compared to the overall population. This also they have shown a benefit of 0.5 hazard ratios, but very good benefit if they have a positivity in the IHC testing. To summarize, the upper GI, the gastric cancers have a significant improvement in the past 5 years, the treatment landscape, and there are novel approaches which are available for the resectable disease, but there are numerous targeted therapies which have been approved and which are in pipeline. And testing for the biomarkers is the most important thing when you are choosing the therapy. The future would be like testing all of them newly diagnosed cancers with the NGS testing, along with the established testing of HER2, MSI, and PD-L1. We can check for the other biomarkers like FGFR, EGFR, MET, and as well the claudin expression. And biomarker unselected populations, we have an anti-VEGF drug, ramucirumab. So with this, I would like to end, and I thank once again for the organizers for giving me this opportunity.
Thank you so much. Any questions? So, sir, we go for the PD-L1 or MSI and this TMB. All three at once, or there any
It's
sequence is there?
No, it's better to get them tested at once initially itself, because it doesn't correlate. Like most of the tumors, it's not like if MSI is high, the PDL1 should be positive. It's nothing like that. So even though MSI may be low, the PDL1 may be positive, or the tumor mutation burden may be higher. So maybe tumor mutation burden will keep it for the second line and the third line. But upfront cases, when you are checking, we have to check both MSI and PDL1.
Okay.
Burden is say cutoff high. So how do you correlate that figure? Because I mean, do you really rely also on TMB in that scenario, or would you like to? My question is how do you incorporate immunotherapy in such setting where MSI is not high and TMB is showing high?
Yes.
You take TMB as a whole biomarker in
Yes.
itself.
Maybe like when you are exhausted with all the lines of therapies where nothing is available, then at that time when you test for the TMB, if it is high, then we can again use immune checkpoint inhibitors if you haven't used earlier.
But not in the first line.
Not in the first line.
We have two biomarkers like EGFR, the HER2, and the PDL1 positivity. How you're going to choose actually?
So there's a trial like Keynote 5, 811, which have showed even though irrespective of the PDL1, the pembrolizumab have shown a very good response rates, almost like 23% extra. When you have both the biomarkers positive, it's better to incorporate both of them along with the cytotoxic chemotherapy. Add both trastuzumab and pembrolizumab. Yes.
The triplet.
Yes, sir. Yeah.